So for time's sake, let's go ahead and get started, everybody. I just want to thank everyone who is involved today, everyone who signed up, everyone who is a sponsor, and everyone who is on our incredible panel. So without further ado, I have a short video to share with you guys.
Good morning. My name is Tom Briody, and I am the President and CEO of the Institute on Aging. And it is my pleasure to welcome you to this morning's panel on managing dementia care. We believe that dementia is the #1 health issue of our time. The #1 health issue. And IOA is committed to supporting families both through direct service and education as they support their loved ones dealing with the diagnosis. Today we bring together some of our community's experts around dementia. And I'm quite confident that each and every one of you will be able to take away a nugget of information, a little piece of wisdom that will help you better manage the care for your loved one. So I wish you a wonderful session this morning. And at this point, I'd like to turn our program over to Allison Moritz, who is today's moderator. Thank you.
All right. Thank you, Tom. That's me, the program director with the Institute on Aging. So thank you all for having me, and I'm looking forward to this. I also want to give a big thanks to AARP, and they have a short video to show us.
Okay, Dad. 1, 2, 3. You saved me. Dad?
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
Okay. Sweet. That's wonderful. We would also like to give a huge thank to On Lok and PACE and the Alzheimer's Association, as well as UCSF Memory and Aging Center, Department of Neurology. For our first speaker, we're going to have Dr. Teresa Pham with On Lok PACE. Then we're going to go into Stefanie Bonigut, who's with the Alzheimer's Association. Next, we'll have Sarah Dulaney with UCSF Memory and Aging. And then Samara Miller with the Institute on Aging. And before Samara, we will get to hear from Lee Giannoni, family caregiver. So without further ado, I'd like to pass it over to Dr. Pham.
Good morning, everyone. Can you hear me? Yeah.
Yes.
I will be speaking on the medical management of dementia and highlighting some areas that are relevant to you as caregivers. Next slide, please. Sorry. So this, hold on for a second. This visual from the Alzheimer's Association emphasizes the importance of a comprehensive approach in providing care to seniors with dementia. It places the individuals and their caregivers at the center. The primary care provider is one member of a larger care team supporting the needs of the individuals. In addition to the medical diagnosis and management, it's equally important, if not more important, to address the functional self-care and safety needs of the senior. We need to have discussions about future health wishes. It's also essential to support the caregivers who are critical members of the care team. Next team. There are currently 2 classes of drugs approved for the treatment of Alzheimer's dementia, cholinesterase inhibitors and NMDA antagonists. They have been shown to have modest benefits in slowing the decline of some cognitive and functional measures, but they do not stop or reverse progression of the disease. Common side effects of cholinesterase inhibitors include nausea, vomiting, diarrhea in up to 20% of patients. They can be better tolerated when starting at low dose with gradual increase in the dose over several weeks. Namenda is better tolerated, but may have some side effects such as dizziness, headache, confusion, and constipation. Next, please. 60 to 90% of those with dementia have one or more behavioral and psychological symptoms during the course of illness. These include aggressive behaviors, hallucinations, delusions, and depressive symptoms, and can be a significant contributor to caregiver stress and burnout. Non-pharmacologic therapy and environmental modifications should be the first line of treatment. Our subsequent speakers, Sarah and Stefanie, will further discuss strategies for managing these behaviors. Next, please. While there may be some day-to-day variability in the chronic behavioral symptoms, a sudden change or a decline from baseline cognition or function could be an indication of an acute medical condition, such as an adverse drug reaction, a urinary tract infection, or early pneumonia, or possibly uncontrolled pain. As the caregiver, you can best recognize if there is indeed a change from the usual patterns of behavior. Early reporting, diagnosis, and treatment could potentially prevent an emergency room visit or hospitalization. Next, please. There are currently no drugs approved specifically for the treatment of dementia-related behavior disturbances. Cholinesterase inhibitors, NMDA antagonists, and antidepressants may improve some of the behavioral symptoms. If the symptoms are severe and pose a risk of harm to self or others, we may consider the use of an antipsychotic medication if other interventions have not been effective. Antipsychotics have some limited benefit in reducing aggressive behaviors, hallucinations, and paranoia. However, there are significant side effects with this class, including sedation, dizziness, and worsening of gait impairments. Antipsychotic drugs have been shown to increase the risk for deaths and strokes in the elderly with dementia. As such, a decision to use this class requires a careful evaluation of the risks and benefits and close monitoring for side effects. Ongoing evaluation by the provider is needed to consider a dose reduction or a discontinuation if the targeted behaviors have improved. Next, please. It is important to note that medications, including antipsychotics, do not help with symptoms of dementia, such as wandering, restlessness, hoarding, or uncooperativeness without aggression. These behaviors are best managed by strategies to redirect the senior and focus on providing a safe and supportive environment. Next, please. Sleep disturbances are common, affecting about half of those with dementia. Frequent nighttime awakening and wandering leads to excessive sleepiness during the day. Behavior modifications include increasing daytime exercise, activity, and light exposure. Minimizing daytime napping and avoiding caffeine in the afternoons may help. When present, medical issues such as inadequate pain control, sleep apnea, or depression and anxiety should be treated. We turn to medications last, but we also recognize that the disruption of sleep for the caregiver can take a toll, particularly if there are safety concerns when the patient is up and about. Melatonin, a naturally occurring hormone, is usually well tolerated. Trazodone is an antidepressant that can help with sleep onset when given in low doses. The use of benzodiazepines such as Ativan or Xanax should be avoided as they can have very high risk for causing falls and confusion in the elderly. Benadryl, a sedating antihistamine found in over-the-counter sleep aids, should always be avoided for similar reasons. Next, please. I would like to touch briefly on the subject of polypharmacy. Geriatricians are vigilant about reviewing medications with each visit, as we too often see the potential harms of polypharmacy. Older adults are 7 times as likely to have an adverse drug reaction requiring hospitalization. Over-the-counter medications such as Advil or Motrin for chronic pain can cause increased risk for gastrointestinal bleeding in the elderly. During a rushed office visit, there is a potential risk for adding more drugs to treat the side effects of another drug. Many commonly used drugs have anticholinergic side effects, which can cause dry mouth, constipation. They can also cause dizziness, confusion, and falls, particularly among elderly patients with dementia. Some classes of antihistamines, antidepressants, antipsychotics, and bladder relaxants are among common drugs with strong anticholinergic side effects. They should be used with caution at the lowest possible dose or avoided altogether. Next, please. In a person with advanced dementia, there is little evidence for benefit in continuing lipid-lowering medications, calcium, vitamins. It may be reasonable to consider discontinuing cholinesterase inhibitors in someone with advanced dementia who is at the stage of being dependent on all their care needs. In that situation, the goal of preserving cognition and function is no longer achievable. A large pill burden and a potential side effects may further contribute to poor appetite and increased risk for falls. Deprescribing may actually improve the quality of life. This is a collage created by one of our primary care providers using pills that she collected from discontinuing unnecessary medications in her patients. Next, please. Lastly, I wanted to share some practical tips on medication management for caregivers. During care transitions, always bring a current medication list and confirm that correct doses with the hospital care provider. Lacking information, staff may default to an outdated or an inaccurate medication list from prior stay that's in the electronic record. After a hospital discharge, check with the primary care provider to review medication changes. Medications that were started in the hospital to treat an acute condition may no longer be needed after discharge. Confer with the PCP about any new medications started by specialists. They may be focused on treating one system, but not as informed about the whole picture. Avoid starting more than one new medication at a time when possible. If there's an intolerance or side effect, it will be easier to determine the culprit. Check for duplicate or expired medications in the home to avoid medication errors. Ask about simplifying medication dosing if there is a reluctance to take medications. A medication dose once a day will be much easier to manage than one that's 2 or 3 times a day. And lastly, in the more advanced stages of dementia, talk with your PCP about the continued benefits of various medication therapies and look for opportunities to decrease medications. That's it.
Oh my goodness. Thank you so much, Dr. Pham. And I know we have great questions rolling in. So I just want to remind people that we'll be able to address all those at the end of the session and to keep them coming. And also everyone's cameras and mics are turned off. So you are all set to just use that chat box. But thank you so much, Dr. Pham. Now we're going to go into managing dementia-related behaviors with Stefanie Bonigut and Sarah Dulaney.
Thanks, Allison. Go ahead, next slide, please. So by the end of the few minutes we have together, Sarah and I are hoping that you will learn that behaviors are a symptom of dementia, and you have learned the DICE model for addressing dementia behaviors. And you will also heard and learned an actual case study on using this model to provide strategies to manage the behavior. Next slide, please. This is a list of common dementia-related behaviors that can occur. Most often, behavioral symptoms occur in the middle stage of a dementing disease, but they really can occur at any time. Behavior symptoms are often just a phase, meaning that they will go away, they will stop. The problem is it's really difficult to predict the length of time of that phase. As Dr. Pham said, approximately 60 to 90% of patients with dementia will struggle with behavioral symptoms. And a couple of notes on some of these behaviors. Agitation is a pretty vague term. So if you're talking to your primary care physician or your neurologist about your loved one's agitation, it is helpful to really describe what that agitation is. Is it verbal or physical aggression? Is it emotional distress? Is it restlessness, pacing, shredding papers or tissues? Just really providing information about what that agitation is. Also, I wanted to point out there is a difference between delusions and hallucinations. Delusions are firmly held beliefs about things that are not real. Often we hear a person living with dementia might always be accusing their spouse of an affair. Hallucinations are seeing, hearing, or feeling things that are not there. And this is actually quite common in a type of dementia called Lewy body dementia. And I do want to point out the information in the red box, and this reiterates what Dr. Pham said. Alzheimer's and the other dementias do tend to progress slowly. So if you see a sudden change in cognition or behavior in your loved one, this may indicate that there's some other medical condition going on, and it's recommended that you seek medical attention for your loved one. Next slide, please. So to effectively manage behavioral symptoms of dementia, we need to understand that behaviors are truly a form of communication for people living with dementia. Behaviors are the person's way of telling us that something is not right, that they have an unmet need, and that may not be able to tell us that in a verbally coherent manner. Our jobs as caregivers is to try to figure out what that unmet need is, what they are trying to tell us. What's the meaning of the behavior? What's their message? What is the need not getting met? Please remember that these behavioral symptoms are caused by the disease. It's not that they're not doing their best, that they're not trying hard enough. It's not that they're doing these behaviors on purpose. It's not because they're not listening. I do support groups for people in the early stages of dementia, and we joke in the group that they don't have it's not a hearing problem, it's a brain processing problem. So they truly are trying their best, but because of their dementia, the best that they're able to do at that moment is use behavioral communication to tell us something's wrong. It's also helpful to try to step into their reality. If you could step into their shoes and see the world as they're seeing it, their actions may also make sense. Next slide, please. This is the DICE model that was developed by Helen Kales, Laura Gitlin, and Konstantin Lyktos from Johns Hopkins. It's a very easy to remember acronym. DICE stands for describe, investigate, create a plan, and evaluate. So describing the situation and how the behavior unfolded is really putting on your detective hat as a caregiver and asking the who, what, where, when, how questions to uncover the why. So who was around when the behavior started? What was happening around the person? When is this happening at a certain time of day? And where is it happening? I is investigate. And there's 3 areas to really look at here. Investigate what's going on for the person living with dementia. What's going on with their health at that moment? What about their current medications? What about their sleep habits? Maybe there's a pattern from the past that they're reliving. It's important to also look at the environment. Are there triggers in the area around the person living with dementia that could be causing the problem? This is a real life example that happened with a family I worked with. The behavior itself wasn't so bad. The person living with dementia was overfeeding the dog, and the dog was gaining weight. When we used this model and we looked at the environment, the empty dog bowl was in the kitchen, and she spent most of her time in the kitchen. So anytime she saw an empty dog bowl, she would pour more dog food in the bowl. And of course, the dog wasn't going to refuse the food. So we just had to remove the bowl, and the behavior went away. So take a careful look at the environment. And also it's important to look on what's going on for the caregiver. How the caregiver feels can affect a person living with dementia. A lot of times our people living with dementia mimic the primary caregiver's emotions. So if I'm getting frustrated as a caregiver, my loved one will get frustrated. If I'm angry, they may become angry. And on the flip side, you can make positive changes. If I'm angry and I just start laughing, they may start laughing, and we may be able to diffuse the situation. C is the create. Create a plan. Create a plan to prevent and respond to behavioral symptoms. This can include changing the person living with dementia's activities or schedules to modify for a better day. It's adjusting the environment. It's providing disease education to the caregiver and providing that practical and emotional support for the caregiver and that respite that they so desperately deserve. And that's where IOA comes in. And lastly, evaluate. Monitor and evaluate the plan that you've put together and see if it's really working. Are you actually following the plan that was created? Is it helping? What can be adjusted? We won't always be able to make a behavior go away, but sometimes we can just make it more manageable and less distressing for the caregiver and the person living with dementia. And that really is success. Next slide, please. So using DICE, that DICE model, really results in these things. It responds to the unmet need that the person living with dementia is trying to tell us. It helps maintain their ability to function. It protects the safety of everyone in the household. It reduces the person living with dementia's distress. It reduces caregiver burden. And it encourages a positive and harmonious relationship between us, the person with dementia, and their environment. And with that, I'd like to pass it over to Sarah, and she's going to use the DICE model with a case study for us.
Great, thank you, Stefanie. So here we have a wife that's reporting that she has difficulty convincing her husband to shower. He used to be meticulous about grooming, and now he's only showering once or twice a week. So, and he's also getting angry when she reminds him. So there might be some communication issues going on here. What's going on with the patient? The husband has Alzheimer's disease with memory loss. He has difficulty communicating, which means he was going to have difficulty saying what he's thinking, as Stefanie was saying, and then probably also difficulty understanding what his wife is saying. And he also has loss of depth perception. So this is a really common visual spatial deficit in people with Alzheimer's. And he has chronic back pain that might be contributing to discomfort. The wife is really observant, and she reports that when she's helping her husband to shower, she notices that he's really wary of getting in the shower, and he seems especially disturbed or distracted by the glass door and the running water. So again, with people with Alzheimer's and visual spatial deficits, shiny objects like mirrors and windows and glass can be disorienting. So next slide, please. Here are some general strategies for reducing resistance to care. We want to first focus on setting up and adapting the environment. And number one strategy here is reducing clutter. If we have a lot of toiletries on the counter or in the shower, people can be really confused by that and not know where to begin. We also want to focus on our own body language, and in particular, we want to avoid sounding really bossy. We don't want to sound like someone's mother or their, teacher or someone with authority, because that's going to automatically trigger some defensiveness. We want to really try to connect with the person, not just focusing on the task or what we're trying to get them to do, and we want to support them to do as much as possible. As I said, people have communication difficulty. They have problem understanding what we're saying. So I'm using a lot of words, I'm speaking kind of fast. This is going to be hard for someone with dementia to comprehend. So we want to slow down and use one-step verbal cues. So what does that mean? That means instead of saying, let's stand up and go to the bathroom, we're going to take a shower and get dressed and go get some coffee, you might just say, stand up. And for each task that you want them to do, you have to really break it down. It might even be scoot forward in the chair, lean forward, stand up. So really thinking about how to simplify and break down the instructions to help them understand. You also want to use gesture and demonstration. So if they're not understanding and you want them to brush their teeth, for example, you can, like they're showing in the picture, brush your teeth behind them so they can see what you're wanting them to do. In addition, you can use tactile cues. So putting an object in their hand, like a washcloth, and helping them put the washcloth to their face so they know that you want them to wash their face. If the activity is really distressing and uncomfortable for the person, you can try to use distraction with something like a pleasant conversation about something neutral, or something like music or a reward. You can also consider alternatives. So for example, in this case study, the patient's only showering twice a week. Well, maybe that's okay. And on the days where he doesn't take a shower, they can do a little wash up at the sink. And as long as he doesn't have any rashes or skin problems, that's probably adequate for his health and hygiene. You also want to treat any underlying pain, because that can contribute to irritability and conflict. Next slide, please. So getting back to this case study, we wanted to reduce the conflict with the caregiver and her husband. And so instead of having her nag all the time, we're going to try scheduling the shower on a calendar where he can see it, and then taking advantage of those natural transitions during the day, like waking up or going to sleep, or if you have an appointment or you do an activity like going to church, that this would be a time that makes sense to them, that they would need to take a shower and get dressed and change their clothes. We can also talk about avoiding embarrassment by using distractions like music or singing to make it more pleasant. Maybe he's particularly embarrassed about having his wife help him with the shower, and maybe someone else might be more successful. And also addressing pain. So in the environment, you might consider adding a grab bar and a handheld shower head if you don't already have one, to help increase safety and independence. Sometimes being able to hold the water can make it less disorienting for people. And consider covering the glass with contact paper to reduce glare, or a curtain or something like that. Next slide, please. I want to give some general tips for toileting and incontinence care. Like Stefanie and Dr. Pham said, you want to report any new symptoms to the provider. So incontinence is a symptom of dementia, but just in case, if the person was able to go to the bathroom before and they have new incontinence, you want to make sure to report that to the doctor. One of the initial strategies that help people maintain continence for as long as possible is a toileting schedule. So this means helping someone to the bathroom every 2 to 3 hours. And again, you don't necessarily need to set an alarm clock to remind you every 2 hours, but take advantage of those natural transitions, like when they wake up, go to the bathroom, before meals, go to the bathroom, after meals, go to the bathroom. And, because people with short-term memory loss will forget, and they may actually need help finding the bathroom. So this can be helpful. You also want to use subtle communication strategies. So not pointing out that someone forgot, and just, maybe ask them to follow you, and then be like, oh, let's go to the bathroom before we go for a walk, kind of a thing. I also just want to say there are a lot of products out there that can be really helpful, as in the moderate and advanced stages. And I would recommend that you talk to your provider. People like home health nurses can be really helpful in helping you identify supplies and equipment. So for nighttime incontinence, things like a nightlight to help people find the bathroom, a color contrast toilet seat, or basically a colored toilet seat, can help people if they're missing the toilet. Using a urinal or a commode at the bedside can help with nighttime incontinence. But day toilets are not commonly used in this country, but they're used by a lot of people around the world. And for families that have bought them, it's been something that's really helped people maintain hygiene and independently for longer. Absorbent pads, both for mattresses and seats, as well as pads you can insert into underwear. And then absorbent briefs come in all different shapes, sizes, and absorbency level. So there are cloth ones that can just kind of be put in the drawer in lieu of their previous underwear that are absorbent. They're disposable pull-ups. And then tabbed briefs tend to be the most absorbent when people are fully incontinent. And for those that have large volume of incontinence, they make extra absorbent, like all through the night absorbent briefs that can be helpful for avoiding leaks. Wipes, skin cleansing creams, and protective ointments are really helpful for preventing skin breakdown and rashes. And for some men who have, maybe like a Parkinsonian disorder or mobility problems, a condom catheter may be appropriate. Next slide, please. And here are some resources I just wanted to share, as well as Stefanie and my contact information. And I believe that you'll have a copy of these slides for the future. Thank you.
Oh my gosh. Thank you guys so much. Such an incredible amount of information. There will be a quiz later. Just kidding. I would love to pass the floor over to Lee, our caregiver. Hi, Lee.
Hi, good morning. There I am. I'm Lee Giannoni, and I'm the caregiver for my wife, Bonnie. And Bonnie has Parkinson's disease and Parkinson's disease dementia. And I'm going to tell a little story this morning. Unfortunately, it has to be very brief because I've been living with this situation for 10 years and I have about 5 to 10 minutes to tell it. So let me move on. Bonnie and I have had a wonderful relationship for 48 years. We've been married. As you can see from the picture, she's full of life. And that picture signifies what Bonnie truly is, or was. Today, not so much anymore. The Parkinson's disease and the Parkinson's dementia has taken that away from her. We have one son who lives in Portland with his wife and two boys. Their ages 8 and 5. We don't get much of a chance to see them because of the COVID virus, but we're doing the best that we can. Bonnie developed her symptoms about 10 years ago. She ended up having kind of a floppy foot a little bit as she would walk. And we went to full tests, the ABCs of all the tests that you do. We really couldn't come up with a diagnosis. It was always come back and see me in 6 months, and come back and see me in 6 months. And after about 2 years, finally, Bonnie was diagnosed with, I'm just drawing a blank here, focal dystonia of the right foot. And basically, in a non-medical term, maybe some of the medical people will correct me, but the neurons aren't properly working with the muscle, and the muscle doesn't react as it probably should. And so after the diagnosis, almost as an afterthought, the neurologist said, oh, and by the way, you have about a 50% chance of this transitioning into Parkinson's disease. Excuse me, I'm having a mental lapse here. I'm having my own issues. It develops into Parkinson's disease. Well, that was just an absolute blow. But we went on for the next 2 years of treating the focal dystonia with Botox, electrical stimulant around the calf, and physical therapy, and with moderate success. We really didn't really train that muscle to do very much. And after a couple of years of this, we had another meeting with the neurologist, and he said, Bonnie, you have Parkinson's disease. And of course, that was an absolute shock. And he said, but fortunately, it's late onset. You probably will not die of Parkinson's. So you're gonna just have to adjust and live with it. So that was obviously a devastating shock, but what he didn't say is that you probably have a 50% chance of developing Parkinson's dementia. And of course, we went on and we started dealing with Parkinson's disease. At this point, I had to make some decisions as to what we were going to do. I have had and have bladder cancer and prostate cancer. We have a very small family. Bonnie only has her mother still living. She's in a memory care facility. She's 99 years old, and her father and brothers have passed away. And so there's no other close relative. I have, of course, my son, and my lovely sister that lives in Marin County that is very supportive. But I was always thinking, what happens when I die? What's going to happen with Bonnie? So we looked into a continuing care facility in Cupertino, California. It was called the Forum. We actually investigated that much sooner than we needed to, because we brought Bonnie's mother up from Southern California after her husband passed away. And we found that facility for her. And since we had already gone through the investigation, I said, well, that's obviously where I think we should move into. So we purchased an apartment, but we didn't move in completely initially for about 2 or 3 years because we still maintained our house. We would actually go there on weekends and met a lot of people. It was great. It was a wonderful facility, really a Class A, well-run facility. Then Bonnie's condition deteriorated. We had to spend a little more time. I wanted to spend a little more time at the Forum for the support that was available. And so over the last couple of years, we were at the Forum. And that was great. Then January of 2020 occurred. And I don't know if you know what happened in 2020 occurred. We had the coronavirus. And all of a sudden, this wonderful facility that was taking care of us turned into a virtual prison. The doors were locked, the gym was shut down, the pool was shut down, the dining facility was shut down, library. We were told not to communicate with with social distance. We couldn't gather. Most we could do was leave the apartment and maybe go on a walk or something. That was our exercise. And no social contact at all. And that was very difficult, to say the least. And can you imagine living in a one-bedroom apartment with somebody who has Parkinson's dementia? Prior to even living there, I was having difficulty communicating with Bonnie because she just wasn't able to. So we, and I make the analogy that it was like living in a prison under solitary confinement. We would get a knock on the door in the morning, and there would be a brown bag at the door with our food. And then we'd pick up the bag, and lunchtime there would be another knock on the door, and we'd pick up I don't know if you've ever seen a prison movie where people are in solitary confinement, but that's what it felt like to me. It was horrible. So after 6 months, I decided to make a prison break. We still hadn't sold our house. So Bonnie and I, in June of this year, moved back to our previous house. Right now, I have a caregiver that my lovely friend Samara Miller provided for us. That's working out reasonably okay. There's some issues there, but I'm having some difficulty at this point because Bonnie's dementia has progressed significantly. And I'm dealing with that and just having some difficulty with it. I'm not feeling very good myself. I'm depressed, lonely, feeling helpless, and I don't feel like I really know what I'm doing at this point. So that's basically where I'm at. And I would love to go into more detail, but I'm going to have to end this story. But the story isn't ended. It continues on. So that's all I'm doing is maybe stopping for a moment, and I'm going to continue on. And maybe at another time you'll hear the rest of the story. But for now, that's it. And I want to thank you for listening.
Oh, Lee, thank you so much. That is incredible to hear. Thank you, thank you, thank you. Last but not least, we have self-care for caregivers. And Samara Miller, take us away.
All right. Hi, everyone. Welcome. Thank you for joining us. Next slide, please. Okay, being a caregiver and how it changes everything. So being a caregiver is not something that we signed up for or thought we would ever be doing. We find ourselves in this role because out of love, a sense of duty and obligation. Because of this, it changes everything. It changes our relationships, our role in the family, our role with the loved one that we're caring for. It also changes our routine. And the other thing that it gives us is it gives us a big, huge bundle of emotions and feelings that we're typically not used to feeling. Next slide. How to care for yourself. Next slide. Okay. Something that is really, really important and was talked about in the previous slides was seeing your loved one for who they are. It's really, really important, not only for your own well-being, is to see that person for who they are at that moment, not who we want them to be, not who we wish them to be, not how they used to be. It's a lot of loss with this and seeing, and it takes a lot of skill and skill set. Also just understanding that, they said before, that they don't have control of their situation or who they are. They are because of who they are right now is because of the dementia or the Parkinson's or the disease. A lot of common feelings and understanding them. The people that I work with and the families that I work with, even my mom and myself, I always tell people it's really, really important not to finding that balance of not having resentments and regrets. So it's important to have both of those. A lot of the feelings that we typically feel that we may not be used to feeling is anger, frustration, loneliness, isolation, also kind of finding a new sense of love that we had for this person. We also are to feel hopeless at times. We also discover that we have a new sense of resilience, understanding, having compassion and kindness for ourselves. When we have these feelings, it's important to embrace them, allow yourself to feel them, not kind of push them away, and then let go of them. Also, one of the other interesting things about feelings was an individual that I worked with a long time ago. He said to me, he said, Sam, a lot of people call me Sam instead of Samara. He said, Sam, he said, I don't know how to feel. And he's like, I don't understand my feelings or how to feel. I also had an individual that said, I'm not angry. I don't know how to feel anger, as he's sitting there with his body language like this. And then about a year later, he's understanding that the feelings of anger. The other thing is to really find something that makes you happy and gives you a sense of purpose. It's different for everybody, but having that, being able to do that is very important. Next slide. So some of the things that we often recommend for individuals who are caring for themselves is join a caregiver support group. Caregiver support groups are amazing. It allows yourself not to feel so lonely and isolated, because being a caregiver can feel that way, and that it feels that you don't have anybody else or don't understand that no one else is going through what you're going through. There's lots of caregiver support. Make sure to take a break. I had a lady yesterday that said, Sam, I really just need a break. Can we have a caregiver come this day so I can have a day to myself? Take a break during the day. It's really, really important to have those breaks, to have those boundaries, to have the routine, anything to make sure that you're caring for yourself. You don't want to lose yourself being a caregiver. You want to make sure that you continue to make sure that you find who you are and find that person, that you're not wrapped up and lose yourself into caring for this person. Another great thing is to hire professional help. It doesn't have to be every day. It can be a few times a day. Lee had mentioned that he does have a caregiver, and there are some issues with that. His wife doesn't like having a caregiver, and often individuals don't want to have outside help. They feel they want you to help them. Like, it's your job, you should be able to. So often the people that we're caring for become very entitled, but they also don't want your help. So it's like a double-edged sword. So it's really important, if once you do start having the hired help, to continue on that path. It's kind of almost like taking your child to daycare for the first time, and they're crying, they're upset, and they're throwing fits, and they don't want to go back, but we just have to continue with that routine. The next slide. Okay, so Institute on Aging is a great organization. It is an organization that I work for. It has lots and lots of programs. We have an amazing home care, and we have Friendship Line, and then we also have a new dementia program that will be starting at the beginning of next year. So this is the number, which is our basic number, and then there's the website thing. All right, I guess that is it.
Oh my goodness, thank you everybody, that's incredible. So let's jump right into the Q&A. If everyone wants to go ahead and turn their cameras and mics back on, we can go ahead and get started. The first question is, why is dementia like the #1 concern for IOA, and how does dementia define aging? If anyone wants to field that.
I guess that would go to someone from the IOA, no?
Yes. So I can speak briefly a little bit about it. As Tom had mentioned, that dementia is probably the #1 health concern. People are living longer. Institute on Aging their whole mission statement is about helping and supporting individuals age in place or age. And so we are recognizing that dementia is becoming a very common occurrence in everybody's daily lives. It's interesting too, where Lee was talking about his wife having Parkinson's, and now is turned into dementia and Lewy body dementia. And so now we have to really understand that. So dementia is often there as individuals grow older. And so now we're just really learning how to educate, how to care, and to really help our people understand what is dementia and what to do with it.
Perfect. Thank you, Samara.
Can I pop in there too?
Yes.
Dementia is not a normal part of aging, but with so many, the older adult population growing, the rates of dementia are increasing. And again, while it's not a normal part of aging, as people live longer, as Samara said, there's more and more people with dementia, the different forms of dementia. And since there's no way to treat or cure any of them, it is really becoming, as Tom said, or he may not have said, but it's really a public health crisis for our country.
Yeah, well said, exactly. Somebody asked if there's any research or even opinion regarding the use of CBD for sleep management.
Anecdotally, I've seen patients and families use CBD on their own, and it seems to work about as well as anything else, which is not great. So I think, it's from what I've seen, relatively low risk for harm, particularly if there's no THC. I would avoid products with THC, particularly in people who have psychotic symptoms like hallucinations or delusions, because those can be exacerbated. But there are also things like melatonin that are worth trying, and some sleep medications that, the thing about sleep medications, interestingly, in people with dementia, is that low doses tend to work better than high doses for things like trazodone or mirtazapine, and maybe Dr. Pham wants to speak to that.
Yes, I would agree. I mean, I think melatonin is relatively, benign, and it often does help. And then low doses of trazodone as well. Completely agree. I don't have a lot of experience in using CBD, so I can't speak to that.
Great, thank you guys. Another question for stroke triggered dementia. How different is that? How different is that from other dementias? And so if somebody's mother, for example, has deterioration from a stroke, but is overall relatively coherent, how could we compare those dementias?
The time course of vascular dementia tends to be more of a stepwise. And so someone with vascular dementia may have a decline and stabilize for a period of time. The focus on the treatment is on also managing the risk factors that contribute to stroke, cholesterol, blood pressure, controlling diabetes. But from the other aspect of, managing the function and the safety, all those things are very similar.
Great, thank you. Can anyone speak to Seroquel and how that helps with sleep and maybe its safety in general?
Well, Seroquel is in the class of antipsychotic drugs, and so it comes with all its potential side effects, increasing sedation, which, that may have a benefit for sleep. I do think that that would not be my first drug to go to for using for sleep concerns. But, if someone has psychotic symptoms, paranoia, hallucinations, delusions that are really very disturbing and keeping them from sleeping, then there could be a role for that. Sarah, do you have thoughts on that?
I agree. I think it's not first line unless maybe someone has psychotic symptoms in addition to sleep disturbance. Maybe I would think about it sooner.
Great, thank you. Also, I just wanted to reiterate that this will all be available later for everybody, and we could do follow-up questions via email. So somebody else asked, how can I make the transition from home care for my dad with dementia to a retirement community with a memory clinic? So he is very resistant and has paranoia of people stealing his stuff. We see that a lot, so.
Yeah. If you want, we can actually, I can actually answer that question. I can answer that offline or something like that if you want to email me or give me a call, and then I can talk about that, because there is a process with that, but there is lots of communities that do deal with that and are very caring and wonderful for individuals to go to.
Great.
One way to also think about is how you kind of talk to him about the idea. A lot of times we say, they're going to a hotel or a resort, and you bring them there at lunchtime, and so you can introduce them there and get them distracted with something on the day of the move. So kind of thinking about how you can talk to him about it if he's resistant.
Great. Anyone have any tips on giving meds in general?
I mean, I mentioned this earlier. I mean, I definitely would talk to the individual's doctor, but we often find medication that we're able to grind up, and then we put it on ice cream or pudding or applesauce, or mix it in with a little ensure, but that often does work. Another, I think one of Stefanie brought up was, saying that it's a vitamin. So it's definitely getting kind of creative about taking it. Often if individuals don't want to put something in their mouth, they'll spit it out, or they just won't take it, or they'll say, oh, I'll take it later. And they won't take it, and you'll find the pills just sitting there. So those are very common things that we use and do.
Yeah, and I also mentioned in the chat there that, as Samara said, calling it vitamins, because as we talked about, there are triggers, and the words can be triggers. Shower could be a trigger. Medication can be a trigger for folks. So calling it something different, and then also trying to normalize it. So I think I put in the chat, if you take medications, or even if you don't, find some vitamin C, and you just put their medication down in front of them, and you take your vitamin C, and it's time to take our vitamins. So it's not something that they're doing wrong, or you're pointing out that they're impaired. You're both just doing something that's a normal part of life.
Yeah. Or having it be their part, exactly what Stefanie said, having it be part of your routine as well. So you're eating breakfast, you're taking your vitamins, quote unquote, on vitamins.
I find pharmacists helpful, like especially if a pharmacy will set up bubble packs, or just setting up a Mediset or some way for someone to be able to manage their meds more independently. Even if you're administering them, just setting them out next to their breakfast. And I think Stefanie also mentioned, taking your meds or your vitamins when they do. So that's a way to demonstrate or model without actually telling them what to do. So all the ways that you can kind of avoid bossing them around as much as possible.
I want to address a quick comment, or rather a question, but is it okay to forward this on to other people? Absolutely. Once this is done, the recording can be disseminated to whomever would benefit. So next question, this is a big one. How do you recommend handling aggressive behavior in people with dementia?
DICE.
DICE model.
DICE, and if the situation, we can add to DICE, what is the distress level and what are the safety risks? So if the person is at risk, I think Dr. Pham mentioned this in her presentation, if there's risk for harm to the person or the caregiver or other people, or the distress is just, really high, then you would consider medications in addition to DICE, but always DICE.
Yeah. One of the situations that we find a lot is that individuals get very aggressive, especially when we're trying to do showers or personal care, or we're trying to get them to do something that we want them to do, or that we want, think that they should be doing. So I always let our home care aides know, and as well as the people that I work with, that it's just really important to be patient when you're giving a shower, not to have an agenda. You can spend, it may take a few hours, but just to kind of get creative. One of the things that my mom does is for my grandma, is like, if she doesn't want to get in the shower, she sits on the toilet. My mom, if she can't get in the shower, then she just does a quick, bed bath on the toilet. So get creative as well. But really just to have a lot of patience and establish those boundaries in a nice, kind, compassionate way, and not to get angry, because what I think that was something that Stefanie and Sarah had brought up is that if you become angry, they sense that and they feel that. And so they respond as well. They can also intuitively really there's that part of them that they may not be able to process everything, but they can feel and respond to what you're feeling. So if you're feeling agitated or anxious or scared or impatient, they will respond to that. So it's really important to, when you are caring for them and supporting them, to do it as much as you can out of kindness, compassion, empathy. And another really good thing to do is to laugh, was to find laughter in a lot of things too as well, because that kind of takes away the aggression and the agitation, and it breaks up that part. And so it's definitely something that really is beneficial and helps. So finding laughter is huge.
And to piggyback on Samara, as she said, you're doing it with compassion. If you can try to step into their shoes and try to see the world as they see it, how would you think about how you would feel when a quote unquote stranger, you may be their daughter helping them in a shower, but if they're not remembering you right now, you're a complete stranger and you're in a very vulnerable position because you're in a shower. It's a cold, well, it could be a cold environment. You're feeling vulnerable. So trying to really get that compassion and trying to understand what they might be feeling, and then using all those steps to dice to really dissect the situation and see what you can change to help manage that aggression so that it doesn't occur, so that you can mitigate that aggression before it even starts.
Well, that's a perfect comment to segue our next question about how do you get a caregiver welcomed in the home who might be, they might be resistant to, even if it's you, right?
If it's you're introducing, say, Institute on Aging home care, you may say, oh, I have a friend that's coming over, and slowly introduce them as a friend. You may be home with your loved one a lot more now, and so you can actually have that interaction, which I think somebody in the had mentioned, well, what do I do when I go back to work? If you do that now in your home and you're helping them build that relationship, then you may be able to get back to work out of the home and feels comfortable that everybody has that trusted relationship.
We also, depending for the home care, a lot of times our home care aides are assistants, so they're not, because, a lot of people are like, I don't need a home care, I don't need help, but they love having an assistant. So we do the assistant, the friend. We also do, a lot of times we'll say the doctor ordered this, and this is something that the doctor wants. And a lot of individuals will respond to that because they respect authority, they respect their doctors, and the doctor knows best. So those are some of the tricks that we use. And it's really, really important to be consistent, that once you start that, really, really continue, even if you're getting resistance, and a lot of times the person will be angry with you or be upset with you. It's important to keep that consistent, and eventually they may get used to it and they may not, but it's really important to have that additional support for your loved one as well as for your own well-being.
Perfect. I know we're hitting our 12 o'clock mark. We will be able to stay on and field more questions, but for those of you who can't stay the whole time, this will be sent out to you so you have full access to this. The next question is the $1,000 question. How can we afford these services?
I think this is such an important question. And I just want to say, I think this is really an area where we need to advocate for policy change and recognize that the burdens of care for dementia are really falling on family caregivers, and where our society is really just kind of, I think, taking advantage of our willingness to take care of people, without giving caregivers the support they need. And it's not that way in other countries. So I think that, that's my answer.
There's there are resources. It's just finding out what resources kind of fit your niche. And Alzheimer's Association is a great place for resources. Institute on Aging is also a great place for resources and stuff like that. So it is, but I definitely agree with what Sarah's saying.
And with advocacy, we are inching forward and forward, but it's going way slower than any of us who are caregiving for people with dementia want. So in the meantime, connect to these services that the Institute on Aging has, that other community resources out there to help keep you and your loved ones safe and content. And then hopefully you won't be using those long-term care facilities that, yes, most of us can't afford.
And I just want to also address, Liz asked a really important question. Does Medicare cover the cost of any of these services? The answer right now is no. And the hope is that in the future they might. So, you know, I think more insurance companies are adopting a model like On Lok. So I just also want to plug On Lok, that On Lok does provide these services. And, you know, you can look into their services, these PACE programs. That have been shown to be really effective. And accountable care organizations are types of Medicare insurance plans that provide more wraparound services like PACE programs like On Lok, and most of the ones that exist right now offer really limited help with things like meal delivery. And this is again where I think we need to advocate and say, what we really need is 10 hours of respite a week, or 20 hours of respite a week, or whatever it is. So I think no, right now they do offer home health, which is a skilled need, and they offer some help through programs like hospice. Unless you're in a program like PACE, like On Lok, and hopefully we can advocate for more coverage in the future.
Absolutely. And in January, with the Institute on Aging's rollout of a companion program that's designed specifically for that. So it's going to tie in the enrichment center, which is care during the day, home care. And you'll have a personalized care coach to really be with you through this experience at a really affordable rate. So we're addressing that. And yeah, just like everybody said, it's evolving. So we have about 3 more minutes left. A quick comment is, yeah, dairy and iron can contribute to constipation. Another good thing to know. And again, any question that was unanswered, those we will answer them in email and get back to you guys. I see one last question here. Someone says, how important is a diagnosis? They know their loved one has something and is resistant to seeing a doctor. So how important is that diagnosis?
I think it's important so that you can actually access more resources, right? And you can access professionals who could also guide you to getting those resources. And then in terms of the different types of dementias, there are some distinctions, and there are certain types of dementias where the use of antipsychotic would actually cause more problems. And so that distinction can be helpful.
I agree. And I think it'll be more important in the future when there's hopefully treatments.
And a diagnosis can really help you plan. I mean, overall, there's lots of things that we can generally say about the different dementias in terms of planning for the future. But as Dr. Pham said earlier, vascular dementia is stepwise. So knowing what the progression might be based on the type of dementia. And knowing the symptoms. I have a client that for 3 years, her diagnosis was young onset Alzheimer's, and it was recently changed to Lewy body. It makes a big difference because for 3 years, she wasn't having memory problems, but she was having the hallucinations that are so common with Lewy body. So it's really, it can be very important to know what the differential diagnosis is.
Perfect. Well, that is our time, and we will get back to everyone's questions. This will be sent out. It has been recording. I just want to give a huge thanks to our sponsors and to all of our panelists. Thank you all so much, and all of you caregivers and interested people out there.
Yes, thank you, caregivers.
Thank you.
Be safe.